titled this panel Redefining Health Literacy, which is pretty much the call to action for this policy consortium. It's not about making kind of small bore impact on health literacy and patient and literacy for the healthcare community. And I don't know why I'm not in the frame, but it's about really looking at structural literacy, at organizational literacy, at physician literacy in life. I loved when Rita Sharon was talking about how physicians had to be literate in life. There was no way, move over physics. Ashley just gave me the best instructions. That physicians, that patient literacy in clinical care meant nothing if physicians weren't literate in life. And I think what we're really trying to do with this panel is to turn everything around, to turn it a little bit everything on its head, and we talked a lot in our panel call about power, about control, about sharing power. And I loved the concept of radical listening. We talk a lot about active listening, but I think radical is a little bit more call to action. The other thing we talked about was the bi-directionality of communications, that it wasn't just that a lot of health literacy has been focused on and centered on, as my friend Rachel Grob said, making humans speak, talking about things in a medical way, or having humans understand things in a medical way, but actually having healthcare, because it's really healthcare, not just clinical care, be framed in human language and in the language of health of individuals, families, and communities. So I wanted to start, I think, with a question. And if everybody, when we do the opening question, if you would all just introduce yourself very briefly. I introduced you briefly in when we did the run through the agenda. But we talked a lot about relinquishing the power of language and where the power resided in the language, and how that related to health literacy and structural and organizational literacy. And Kim, we talked about how you were thinking about reframing this and the relinquishing of the power of language. And I'd like to ask you to just introduce yourself and comment on that a little bit, and talk to us about the ways that you were talking about reframing and relinquishing of this power.
Yeah, I'm happy to. Thank you, Gwen. So my name is Kim Erwin. I'm a professor of design. I know that raises eyebrows. I am actually at the IIT Institute of Design in Chicago, and I lead its equitable healthcare lab here. My focus is human-centered design and applying it to health systems to improve design for everyone, but especially putting an equity lens on new redesign efforts. So I'm also a communication professor, and the issue of language is near to my heart. I think, the themes that you highlighted, it's like there's wild agreement that power is a component of, or an outcome of, language choice. And so the question about whose language, I think, is a really interesting one, because it's both a familiarity and a power issue, as has been described. So, we've heard from people like the neutral or scholarly language that's used doesn't resonate with lay people. They don't see themselves in data. They don't see themselves in these technical terms. And the use of that kind of vocabulary also creates a need to teach the patient the other language, so that they can converse with providers. I'll give you a small example of the power play behind even small word choices, a very simple example, but we did a study in which we were trying to create an improved discharge document for children coming to the emergency department with asthma attacks. And one of the things that became really clear is that in the context of discussing with a family with a young child how to care for their kid when they leave the emergency department, is that you have people saying, I really need you to use this MDI, which is a particular type of inhaler. It's an age-appropriate type of inhaler for a child. But most people don't know what an MDI is. And so, but residents who typically take this role on are kind of proud of their knowledge. And so they use it because it's technical, it's precise. And physicians are trained to be precise. We went into the south side of Chicago and learned that these inhalers are referred to as pumps. If we went to the school system and the principals, everybody there refers to the inhalers as a pump. On the north side of Chicago, they call it puffer. I can't explain this. Nonetheless, communities have their own vocabulary. Why don't we use this? In the study, we met a significant amount of resistance to changing the terminology on the discharge document. And to the Jackson's point earlier, our negotiation of that was to actually draw illustrations. So you can call it whatever you want, but it looks like that. And so at least it was something people could point to. But I think, that's sort of at a macro level, like communities have their language. Why can't we incorporate that? I've met resistance on that in other contexts as well. So it wasn't just kind of a one-off study issue. But I think that language is at an interpersonal level is a mechanism for building shared meaning. Mm-hmm. So if your goal is shared decision-making and your goal is patient self-efficacy and self-management, then that shared meaning is essential. And whose language it is a really important concept. And it needs to be negotiated to enable mutuality and shared power. And so to kind of reiterate Jackson's point as well, it's not what does this word mean? It's what does this word mean to you? And I think it's really important. Providers are not stupid people. But we took them out of the home context. So they don't do home visits anymore. They only sit in their offices. And we gave them 15 minutes to have appointments. And I think those two things really work against this negotiation process that needs to happen. So providers need to not just be trained, they need to be permitted and incentivized to engage in negotiating shared language.
Well, and I think the other thing, just as the other side of that, providers are not stupid people and patients are not stupid people. And so there is a lot of assumption around health literacy, especially when you're looking at it from the patient framework or teaching patients clinical literacy, is people assume that you don't understand. They assume that you're quote unquote illiterate about something, which is one of the drivers for us to really do this policy consortium around reframing and redefining health literacy. And Debra Joy Perez and I have worked together on a number of projects and a lot all around equity and inclusion, but also around with using anti-racism principles. And one of the things that we've talked about is how, and I think this has been implicit in a lot of the conversations today, is how we recenter this conversation. And how do we recenter this approach to communications so that the people for whom we are creating meaning and the people for whom these outcomes are essential, how do we do that, and how do we recenter that? And could you just talk a little bit about that, Debra, and also, if you can, where some of the concepts that we've been talking about, anti-racism, intersectionality, some of the things that are kind of out there in the universe, how that relates to this whole notion of communications.
Thank you so much, Gwen. I'm so happy to be here. And absolutely, I think we're living in a time when there's an abundance of literature on decentering and recentering. I like that you said recentering, but it's decentering dominant experiences in culture and recentering those that are most vulnerable in the given situation or those that have less power. So in this conversation, I've been loving what I've heard thus far and the prior discussions around who has power. A lot of that is based on asymmetry of information. That's kind of an old economics term, right? Like whoever has less information has less power. And in the dynamic between physician and patient, there's asymmetry of information. And it's just, you could be a scholar, doesn't matter how much education you have, but there's specific language to the practice of medicine that unless you're a physician, you don't get, right? And so there's first that level. The other is, because we're living in the time we're living in where everyone is talking about race equity and equity, there are tools and perspectives and theories that I think the health literacy community can benefit from. So the conversation we had prior to today's session was around whose health literacy are we talking about here, right? Is it the health literacy of the patient? Do they know enough about their disease to know about how to care for themselves? What about compliance? What are all of that, as opposed to measuring health literacy from the physician perspective. How literate is the physician about the lived experience of the patient, right? And so I think if there's an opportunity for everyone on this call and in the work that we heard around the various narrative medicine master's programs to decenter dominant culture. And so that, the phrase has been said many times, our words create our worlds, right? And so just a small example is like when we talk about decentering dominant culture, we're talking about decentering whiteness, right? And a lot of the narrative is around, even in the early days of racial and ethnic disparities, it was whites compared to everybody else. And that's how we define disparities. African Americans and maternal health issues or infant mortality as compared to whites. And so that you have this ratio below or above the line. And what we need to do is reframe the thinking. So it's not about centering the dominant culture, but centering the culture and the experience of those most vulnerable. And so I would offer to the group that there are these tools right now around racial equity that everyone can take advantage of. I'll just name one, and it's based in this theory of kind of liberatory consciousness, right? And that is, how do you kind of address a problem or approach a problem from these four domains: awareness, right, analysis, action, and accountability. And by taking that intentional effort in embedding equity in the equation, you'll be able to come closer to a more kind of I think effective approach in understanding the patient perspective. Is really about, again, decentering dominant culture and recentering the experience of those most vulnerable in that situation.
I think it's also, Kareem, I'm going to turn to you. And Debra, actually, would you just introduce yourself with one sentence?
Yeah, sure. So I'm the Chief Equity Officer at United States Pharmacopeia. It's a nonprofit 200-year-old organization that has a mission of ensuring equitable access to high-quality medicines, food supplements, and vitamins for the world.
A very strong public health mission, global health mission. So, Kareem, somebody said awareness, analysis, action, and what? Accountability, because that, if we have no accountability, then how are we ever going to make any progress? And we can talk about accountability a little bit later. So Kareem, in your experience as somebody who does so much research with the community, not on the community, but with the community, one of the things that we first connected on was the idea, was the way that you stood in the community. You didn't just say, and you didn't just ask the community to come to you, you went to the community. And that's one of our friends and colleagues, Alma McCormick, who's participated in Early Policy Consortium, talks about the work that she's done with her research partner. And she's part of the Crow Nation in Montana. And her research partner created trust and created a relationship over a series of years by going and standing and sitting with the community members. And that's something that you've done throughout your career, and certainly throughout the time I've known you. And one of the things we talked about on our panel call was that experience of going out into the community with and hearing what the community wanted and how that changed the institution or did not change the institution. And so I hope I gave you enough to tell that story, enough of a prompt to tell that story, and also just introduce yourself, please.
Thank you, Gwen, and thank you to the panelists. And I was really excited to be able to join earlier and hear some of the dialogue in other sessions. My name is Karriem Watson. I'm the Chief Engagement Officer for the NIH All of Us Research Program. But prior to joining the NIH, I spent 17 or so years in academia as a community health scientist with my research focused on community-based participatory research, and particularly around cancer prevention and control, in layperson's term, cancer screenings, and in what ways we can improve cancer screenings and access to those in the community level. And Gwen, your question it reminds me of two stories, but I'll tell one that we didn't talk about. And I worked with an organization that was focused on African-American men's health. I worked with that organization probably about 5 to 7 years, Gwen, before I engaged in research with that organization. Now, every researcher may not have the luxury of doing that, but the reason it was so important was because I saw that community-based organization that I worked with just as paramount to my training as a community health scientist as the academic partners that were teaching me. I often felt that I was in dual classrooms. I was in a classroom in the community with that community-based organization, and I was in the classroom with my academic stakeholders and my researchers and my mentors. And it was just as important, and sometimes it's more important for me to pass the test, if you will, metaphorically speaking, with those community stakeholders than it was to be validated by my academic peers. And the reason that was so important for me was because if in fact I was going to be addressing cancer screenings with and for African-American men, I had to have the trust, the relationship building, and I need to know what those men valued as priorities. And so it was important that I was in those barbershops before we engaged in research. I was in those faith-based communities. I was in those fraternity meetings. And so when I then began to do my research on lung cancer screening African-American men, it was not a big jump to get those men to engage with me as citizen scientists. It was not a big jump to get those men to trust me, because they saw me before the research and they knew that I was going to be there after the research. But what was so daunting, Gwen, about that, and to frame it in a health literacy piece and centering around equity, when you think about lung cancer disparities, one of the largest studies that took place had about 53,000 participants in it. Of those 53,000 participants, only about 4.5% of them were African American. But as a result of this study, new lung cancer screening guidelines came out that required a shared decision-making visit. And when I then began to see the tools that were developed for that shared decision-making visit, and I began to share those tools with Black men, they felt that they were left out of the conversation. Those tools were not developed with nor for them, and that they didn't even really begin to know how to use those health literacy tools to help them truly have a shared decision-making visit. So when it came time for those men that were eligible to get screened for lung cancer, was there equity in those tools? Could those tools really be used to let that man and his family make an informed decision about whether or not lung cancer screening was for them, which is what the shared decision-making visit is supposed to do. So we set out on a project to engage Black men as citizen scientists so that they could help inform tools that would be developed by and for them, so that the decision can truly be shared. But the challenge is that institutions have to be ready to engage community members as partners, because even how those men are paid and compensated, even how those men are selected, how the university views those partners, it's often a barrier and a disconnect. So we also have to address the systemic barriers that prevent community members from being equitable stakeholders in community academic partnerships.
Right. And I think that's a really good segue into what we want to talk about as well during this panel is kind of structural literacy. And Kareem, before I let you go, one of the things we talked about was a story of research where you went into the community. Only one of the academic partners went into the community, and so she was changed, but the academy was not changed. So it's fine if one person goes in, but if you'd relate that story, and I'd love to hear any ideas that you and Kim and Debra have about how by recentering, or decentering and recentering, we can really change the structural literacy and the literacy about people and literacy in lived experience and lives.
Sure, Gwen. There was a project that we had. It was a capacity building project where the community partner, which in this instance, he was a faith-based institution, a faith-based organization, was to work with an academic partner. And we were supposed to be doing capacity building on both sides. But as the project went on, we found ourselves as a community faith-based partner constantly telling the academic institution that, well, actually, you're emailing us during the day, you're asking all these budget questions. We don't have a budget office like that. We have a treasurer. It's a church. It's a Black church. Now, it just happens to be a very large Black church, but we had to let them know it's a Black church. We also began to remind them, don't expect to hear from us on Wednesday afternoons, or don't expect to have a meeting on a Wednesday evening, because that's Bible class night. And so then we began to think about the language that the faith community understood with research. And at the end of that project, Gwen, one of the researchers ended up saying, she became so integrated into that faith community that the members of that faith community thought she was a member, because that's just how much she immersed herself in the work and within that faith-based community. But one of the parishioners at the church said, Kareem, it's funny. I feel that we learned how to speak academic, but the academic did not learn how to speak community at the end of that project.
Right. And Kim, we talked about this before. We talked about you talked about awareness, agreement, and ability. And also, how do we create kind of organizational literacy about people, not just about what their, the quote unquote expertise is?
Yeah, I think that's a great question. I'd like to build on what Kareem was pointing out, which is, one very proven strategy is to co-design with community members, rather than presuming that, translating a word or managing word count or reducing reading grade level is the answer. Often the fundamental paradigm is wrong. And so, tweaking language is not the way to go. I think another strategy I'd like to put this out here is medical education has to change. It used to be that if you were a physician in training, you did home visits. And home visits put you into a very different position with your patients. First of all, your agenda is not the agenda in somebody's home. You have to respond to what's in the environment. And I think that Maya Angelou said, prejudice rarely stands up to experience. I think, and I heard from older physicians who were mandated as part of their training to go into home settings. A particular physician was talking about going into Cabrini Green back when that housing project, the legendary housing project, was here in Chicago, and having to do a home visit for a woman whose child kept coming back to the emergency departments, part of my asthma study. And he kept explaining to her, you need to get rid of your cats. Your cats are part of the problem here. He did a home visit and he realized, having, gone through the apartment and taken the elevator where the lights were out, and it was, an intimidating environment. It was also kind of a depressing environment. He walked through the door and he realized this woman's cats were like the best thing in her life. They were really kind of a self-assembled stress management system. They brought her joy. And he realized that was sort of a foolish thing to be standing back. So he changed his tack. He's like, okay, how can we reduce maybe the number of cats? Or can you keep the cats off the bed? Those are more patient-centered strategies that are obvious once you're on site. So I think that the educational model for residents really needs to go back to treating medicine as a social science, because it is. Health is informed by the social conditions. And then I think that might kind of get back to what you were intimating before. So this idea of we have a rational actor model around patients, like if they just have the right information, they would do the right thing. And so that's an assumption that awareness is the problem. This I hear all the time in my work from the clinical side. And I think people are less curious about maybe the awareness is there, but they don't agree with it. And that is oftentimes, for instance, a barrier to adopting or using regular inhalers on the South Side. What we heard in our family visits was those have steroids in them. I've been told, and I'm kind of hip to this idea, that steroids are poisoning my kid. So, that's an agreement issue with a medication, not an awareness issue. And then the third category is ability. So maybe they are plenty aware, they even agree, but there are other fundamental barriers that are cost related or time related, and especially lower income people are reluctant to share those issues with their clinician because they don't want to be judged.
Absolutely. And we'll hear about that. Debra, were you about to say something? Or is somebody in the background saying
No,
something?
I that was my dog, but I'll
Okay.
I'll speak on his behalf and say I want to lift up a couple of things tying an idea that Kareem said and I'm sorry, was just said here, and that is this idea that who are we trying to change, right? Who's the focus of the project, right? I love this co-design issue. If you deliver a program, which often happens, people they have a program they want to test on the community. So the community wasn't necessarily engaged in the design of that, right? So it's doing that co-design. It's also kind of making sure, going back to recentering, that one single person is the only one who benefits. And this is why structures and systems are so important. And when you do equity work, you can't stop at the intrapersonal, like the idea that I'm learning to be more, I need to be conscious of my biases and interrupt my biases. And I'm going to do more kind of learning for me on equity. There has to be that other levels, right? That interpersonal and institutional. So the institutional and structural changes are absolutely essential for real kind of breadth and depth of the systemic transformation we're seeking, right? And I just want to kind of, again, if we're going back to the question of the why we're doing this, why is it important to recenter and decenter? Because the most effective practices in healthcare are those that involve and put the patient in the center, right? So we often say at USP, equity equals excellence. You do the equitable thing, because when you do the equitable thing, it raises the quality for everyone, right? And so I just want to kind of reframe again, going back to decentering, that the reason for doing this and the rationale for doing the hard work of decentering and centering is because overall the outcomes will be better.
And it is what we need to do. It's our moral obligation, and it's our societal obligation. I think the other thing, I mean, I was just sort of thinking, struck me when Kim talked about, thinking the rational actor model. Why don't, we put that on the patient, but we don't necessarily put that on the healthcare provider, that rational actor model. And I think we might consider putting that on the healthcare provider. I think one last, and in a few minutes, my colleague Jamie Trotter is going to come on to see if we have any to moderate the questions in the chat. But one of the things that people have been talking about is that health literacy is code. Health literacy is often code for pattern making. It's often code for bias. It's often code for other things. And it is always something that often something that makes the patient or the family feel less, because in many ways they're excluded by this. And I keep on coming back to Kim's power of language. So how do we not just recenter literacy, but how do we change the code? And how do we make sure that that is embedded in what we do going forward? Because we don't want to, we don't want to be just the subjects of pattern making. We've all been the subjects of pattern making. It happened to me when I was a young adult diagnosed with cancer. It was, you're young, you're healthy, you can't have cancer. There was a pattern that was made. You're a woman, you must be hysterical. I mean, there were so many parts of it. So how do we address this idea of code and bias and persistent racism and sexism and classism? I know I'm throwing lots of isms at you for the last bit of this, but that was another thing that really propelled us to do this, to have this conversation over these few hours with many different facets to it. Debra? I don't know.
Yeah, I guess, I'm happy to start, because I think, it's the question you should be asking yourselves: how inclusive is my institution? How equitable is my institution? There are plenty of rubrics out there to assess levels of equity in organizational change. So it starts with representation, clearly, who is part of the team, who's not present, how do you build a diverse and equitable team, empowering voice and decision-making, who gets a say in the decisions? Is it only the people at the top versus the people who are having the experience? What does authenticity and vulnerability look like in your organization? It was said earlier that there's this perception or expectation that doctors know it all and therefore can't say I don't know, or let me look into that. I mean, there's a certain, but we know that there's strength and vulnerability. Thank you, Brene Brown. And then taking risks to push through those uncertainties and the fear. And above all, I think in order to disrupt bias, it's having those courageous conversations. Be the person in the room who, when you notice a lack of empathy, a lack of cultural awareness or humility, that you build bridges and you call out, call in. When I say call out, I mean you name it. And you call in by asking questions around, did we really mean to say this? Are we really going to do this project without first consulting with community? All of this will lead to kind of more engaged, fair, and frequent contact with patient communities to achieve shared goals. So that's what I would say to kick this off.
Great, thank you. Kim or Kareem, do you have any thoughts on this?
Sure. I think part of that too is as I've been thinking about systems and thinking about this, is that we also have to, and I think Beverly put something in the chat, acknowledging that everyone is human, that both parties, both the provider, the healthcare, and the patient are humans. But I also think that we have to name and understand that systemic barriers, systemic isms exist, right, in healthcare systems in general. And so and sometimes providers feel that, well, I'm not this way, I'm compassionate, I want to do the best thing, but that patient's experience before they get to you may be the limiting thing. That may be traumatizing. That check-in experience at the front desk may be traumatizing to them. So just understanding that these systemic barriers happen. I used to tell my staff all the time when I worked in a group of federally qualified health centers, when a patient was late and it would mess up our quote unquote numbers, I would say, have you ever thought about what that patient's day looked like before they got to that healthcare visit? That patient didn't wake up and decide they want to throw off our numbers and just be late. Something happened in that patient's life. And the last thing that we need to do is not see them because they're late. I understand what this is going to do to the provider, but it can't be that we put the onus on the patient about being late. Let's talk to them about what it meant. And there was one situation I talked to a mother, and she told me that she took a day off of work to get to this visit. And if we didn't see her, she didn't know when she was going to be able to do that again. So we got to understand that life happens, and we got to approach this with a sense of grace. And I don't think we use that word enough in the healthcare space, grace, on both sides.
Yeah, I think you're absolutely right. And I was thinking, I was smiling when you were talking about people being late. Yes, Jamie put grace in all caps and exclamation mark. But my friend and colleague, who many of you know, Meg Gaines, who started the Center for Patient Partnerships at the University of Wisconsin, was asked by, I think, the University of Wisconsin Health System to think about why people were consistently late, and patients were consistently late and throwing off the schedules. So she went around and just asked people, and they said, because we've been looking for parking. We don't have money for parking. So parking vouchers solved many of the problems of lateness. Another person said that another healthcare provider told me on another panel that she would gang up all of one of her patients' appointments on the same day because she thought that was easier for her. And in fact, the patient told her no, she'd rather come 5 different times because then she didn't have to have childcare. She didn't have to pay for lunch outside of the visit. There were other reasons why that was important to her, but the assumption of all of this. The point of all of this is that we make assumptions, we make patterns, we don't ask questions. So we have to listen first, and then we can speak. And we have to ask questions and ask people what they need and what's meaningful for them. I don't know, Kim, if you wanted to add into that. I have one more thing I wanted to ask you to comment on.
Yeah, well, of course, you're talking to a designer. And so our goal is action. I think there's only so much, attempt at describing things that we should be engaging in. I agree with the other two panelists, Kareem and Debra. I think we have to ask why and show some curiosity rather than, the goal should be to understand why rather than to how do we get patients to behave, which is too often, there's a one-way agenda that's driving organizations. And so the only thing I know that ever changes people's minds is direct experience. Like, you can read about a fight in a bar in the newspaper, but being in that bar when the fight breaks out changes your perspective on things, heightens your sensitivity and your priorities. So I think we should all be doing more inquisitory exploration about what is going on, and then we should be building and testing new strategies. And we should be building them with people, not around them. So to Kareem's point about, extended engagement with the community, it changes everything. They will tell you things, they will share things, they will do things with you. But not if you just drop in when you have the agenda and don't show an overall curiosity about what's going on with them and building a relationship with them.
I'll just say one last thing, if I can, Gwen, and that is, whenever you're trying to change systems, right? We know that systems work as they were designed, which is to repel and disrupt the innovation or attempt at innovation. So you should anticipate resistance. You should anticipate, challenges, and remain steadfast. Do it anyway. It is the only way that change will happen is if there's a constant. I at USP, where I am now, I say we need equity to be a constant drumbeat. Like, it's never ending. Like, it's in every message. It's integrated in the work. It's not this separate thing over there. Equity is the work. Centering is the work.
I think that it can be either a drumbeat or a teaspoon. And so going back to Ann Jackson's, a teaspoon at a time, or it can be a quart, to really torture that metaphor. So I wanted to just end with asking all of you if you'd comment a little bit on something that Rita Sharon said, but also this policy consortium actually was built out of, some people know this, but it was built out of our prior policy consortium, which was all around trust and trustworthiness, and much of our work focuses around trust and equity. And so every time some of the things that were talked about during that policy consortium, particularly Olga Lucia Torres, who's on this Zoom, and Rob Wynn, who Kareem used to work with, was about trust. And one of the things that Rita Sharon said in her presentation was that communications have to be anchored in the present tense of trust. So if we're thinking about, I don't like the one last comment thing, but but I'm going to ask you to do one last comment because we only have 4 minutes left. But if you were thinking, what does that mean to you? And how would you approach anchoring? I like that, the notion of present tense, because everything does happen in the present tense when you're a patient or when somebody you love is sick. Kareem, can I call on you since I?
You sure can. There's a slight delay, Gwen, so that's why I was waiting.
Oh, okay.
Yeah. So when I think about this concept of trust, I was just putting in the chat, and I'll answer this in terms of citizen scientists as well. We were doing a prostate cancer screening program, and we went to engage African-American men as citizen scientists. And it wasn't that we, quote unquote, targeted those men to try to do race-based, if you will, enrollment, but it was to first educate these men that they potentially were at higher risk based on, some ancestry things and based on some social determinants of health risk factors. And having trust in that community, we used the citizen scientist model where and with trust, we don't always talk about trustworthiness. It wasn't just enough for the piece of populations being, and someone put that citizen science can be triggering, and I want to acknowledge that, but and we've moved to the term community members, community scientists as well. But I have to note the Black men wanted to be called citizen scientists because they wanted to reclaim their role when they often haven't been viewed as that. So I've definitely struggled with that term because it can be off-putting for some, but it was actually a term that I didn't choose, that the Black men chose that framing of this concept of citizen scientists. But I fully acknowledge that it can be off-putting for some groups. But I want to move us from just talking about the community trusting us, but for us to become trustworthy. And part of that being trustworthy is being present, is being vulnerable on the researcher, on the clinician, on the provider side, so that community can get to know you as well. So I love the word trust, but I also like trustworthiness.
Yeah. And I think that's a really important point, and we often forget that, is that it is that trustworthiness is a critical part of building trust. You have to be trustworthy to be trusted. I also, you'll see in one of the video, Dr. Randy Jones will talk about language and some of the language in terms of the work that he's done with Black men with prostate cancer. Kim.
Yeah, I spend a lot of time on the system side, and I think we have a system that is not wired for trust. I'm not quite sure what it is wired for, because it doesn't seem to be succeeding on any particular measure. I think we have systematically broken trust by designing systems that are optimized for efficiency and cost. And that goes from everything that low-income pregnant women are given residence as primary OBs rather than attending physicians, to triple booking clinics that serve Medicare patients, because instead of being curious about the no-show rate, we just decide to solve it algorithmically by booking more appointments and creating pileups in the waiting room. We have practice models where you can't get to see the doctor you thought was your doctor. You get to see somebody in the practice, but good luck getting an appointment in a timely way for somebody you thought of was your doctor. And then we have these 15-minute appointments where nothing can happen that is meaningful in a 15-minute appointment. I'm working right now on the west side of Chicago with a primary care clinic. It's embedded in a residence on the west side of Chicago, and it's like literally you go down your apartment building. It's in the first floor, and we were timing the length of appointments. There is a U-shaped curve where there's a few appointments that go 60, 70 minutes. The vast majority of the appointments are between 5 to 10. Some of them are less than 3. If you could do away with that 15-minute appointment slot and give people the amount of time that they actually need, I think you could begin to rebuild trust. But we don't have systems that do that. Our systems are fundamentally, I don't know, I can't imagine where they ever came from, but they're very 20th century.
Yeah, that point, Kim, I would say the one you just shared is an example of approaching the appointments from an equity perspective versus an equality perspective. 15 minutes, everybody gets the same, as opposed to giving people what they need. The thing I'll say about trust, Gwen, is, as you know, it's one of the main principles of the patient engagement work that you were leading for PCORI. It's essential. It is part of health equity. You can't advance health equity without trust. But I also want to point out, perhaps the obvious, is that there's a reason for the distrust. It is rooted in historical trauma and experience, and that part of moving forward is this acknowledgement that harm was done, and that people have systems have exploited and treated particularly patients of color and other disadvantaged group poorly. So you can't build the trust unless you acknowledge the past. And then from there, it really is about kind of looking at, going back to the earlier example of how do you advance a more patient-centered health literacy, is looking at the data, really challenging your analytics, how you analyze this data, who's missing, who's not there, and then setting and putting forth an action plan to how to redress some of those past harms.
Great. Thank you. And Ashley just put in the chat, you can't address trust unless you acknowledge the past. And in a workshop on promoting health equity and cancer care that the National Academies did, one of the panelists in the first session said, just tell the truth. And sometimes that seems to be more and more difficult, particularly in our current social situation. So I'd like to say thank you so much to the panel. There were amazing comments in the chat about how rich and full and really inspiring this conversation has been. And thank you for your participation. I knew and thank you for helping to lay out some of the actions we can take in the future.